Welcome everyone to our Suicide Care Research Center public presentation for the month of May. Can't quite believe it's May, but there it is. We are very, very lucky to have Dr. Virna Little here to present on scaling up uh, and how to think about this process of what does it actually take to scale evidence-based practices in the primary care, collaborative care space. Dr. Virna Little is a distinguished leader in behavioral health. She is the co-founder of Concert Health, a behavioral health management group that provides collaborative care to healthcare organizations across 21 states and has served over 150,000 patients. Dr. Little is the co-founder and CEO of Zero Overdose, is a national nonprofit seeking to eliminate unintentional overdose deaths and other overdose events through overdose safety planning. Dr. Little is also the leader of SPiER, an international effort to improve suicide care and reduce suicide events and deaths by optimizing technology, such as electronic health records and health information exchanges. Dr. Little has served as the faculty on the faculty for the National Zero Suicide Team. She's known for her work integrating primary care and behavioral health and has helped implement and advance care across all 50 states. She has served as a consultant with the nationally recognized groups such as our own AIM Center, the National Council for Mental Well-Being, and the Meadows Mental Health Policy Institute, as well as to the Suicide Care Research Center. As a nationally and internationally recognized speaker, Dr. Little has presented at the White House along with other distinguished venues. She's received numerous awards, including 2 Lifetime Achievement Awards, one from the National Council for Mental Well-Being and the other from the Association of Clinicians for the Underserved. Dr. Little has served on numerous boards in the role of board chair, elected member, and advisor. She's published over a dozen peer-reviewed articles along with other reports and briefs, and she holds a doctoral degree in psychology and a master's in social work. That will capture the many of the folks who are participating in this call as well. We are so grateful to have you come and present from pilot to policy impact and give us this larger perspective. And with that, I'll hand it over to you.
Well, thank you. That was a lot. We should have talked. We could have cut that way shorter. But thank you. I'm really glad to be here. What I really sort of wanted to talk about today was certainly scale, um, particularly collaborative care, but also glad to talk about scale in primary care practices. We, along with the Association for Clinicians for the Underserved, we developed a training. How do I identify and care for someone at risk for suicide in a 15-minute primary care visit? And we've actually trained over 5,000 primary care providers and their teams in 36 states. And that has been incredibly helpful in working with organizations, primary care, healthcare organizations, to really understand, identify, and work with their population of patients at risk for suicide. And in fact, whenever I'm going to do collaborative care with a healthcare organization or practice, or so be it, I actually include that suicide care training in that implementation for collaborative care. And in fact, New York State requires it as part of their collaborative care Medicaid program to be able to do some of that work. So just sort of tying some of those things together. I really want to ground everyone, and I always sort of talk about this in terms of grounding everybody in collaborative care, so that we are all on the same page. Evidence-based model, and really the number of diagnoses that can be included in collaborative care has dramatically changed. So evidence-based, we're adding the collaborative care clinician to the primary care or specialty care team. Lots of conversations around these individuals. So collaborative care is a monthly case rate, and collaborative care is actually a primary care or healthcare initiative. It's not a behavioral health initiative. The collaborative care codes are actually primary care codes, and they are a monthly case rate. CMS said, hey, it's our gift to primary care. And the collaborative care or care manager that's added to the primary care team, CMS says they don't need to be licensed. Many are licensed around the country, but because of that monthly case rate, they really have the flexibility to work with the patient maybe 5 times the first week, 10 times over the month, multiple times, sort of based on what that patient needs and what feels comfortable. And that is incredibly helpful. And we often, what we know about collaborative care is that it's the number of contacts, not the amount of time. For every contact, the rate for that patient to have a good outcome increases 13%. And so the patient that gets 10 contacts over the course of the month for 5 minutes each is going to do way better than the patient who had 4 contacts for 40 minutes apiece. And so loving that flexibility there and that monthly case rate, that really is what makes the difference. We know that to do collaborative care, you have to have a registry. And that's because collaborative care is very treat to target, very measurement based. And so we use tools to be able to know whether people are getting better or getting worse. And a lot of tools have been added. So I think a lot of you who think about collaborative care think about, oh, mild to moderate depression and anxiety. That is so not the case anymore. Or think about it in geriatrics. We routinely do pediatrics, ages 6 and up is pretty routine now. And the diagnoses have dramatically changed. So ADHD in adult and children with the ASRS and the Vanderbilt, trauma with the PCL, bipolar with the PMQ and the PHQ sort of simultaneously. Those two were in the SPiER trial. Substance misuse with the BAM, of course, depression and anxiety with the PHQ and the GAD. So all of these tools, the pediatric symptom checklist, the PSC-17. And so a lot of those tools now are used routinely in collaborative care, validated to sort of track the outcomes, tracked on the registry. And then the second person added to the team is the psychiatric consultant. And this psychiatric consultant does not see patients and they don't prescribe. They actually meet with that collaborative care manager and talk about people who aren't getting better or getting worse. So, for the example, someone who's at risk for suicide, they may be talked about every single week in consultation or maybe once a month. But certainly, individuals at risk for suicide are pretty routine in collaborative care. These are the collaborative care billing codes. I think, certainly important to know that they're there. It is of the first month, 70 minutes. And then with a half plus one, it's really 36 minutes of care. Subsequent months are 31 minutes in order to be able to bill. There is an add-on code. Most collaborative care patients are in care about 6 to 8 months, and the average amount of care is about 2 hours a month. It's a base code and then two 30-minute add-on codes. CMS actually pays for 4. Most commercial plans and states are still kind of stuck at 2. So oftentimes we say it's really 2 hours of care. There is a G code for 30 minutes. A lot of state Medicaids and plans don't cover this code, but it certainly is an option. And then there's this 99484 code. A lot of people doing suicide care use this code. It is a behavioral health integration code. It is 20 minutes billed monthly. What people are seeing with this code is that it is not considered a primary care code, and a lot of plans actually will carve it to their behavioral health services. And a lot of the state Medicaids are not covering it. It also does require you to have a validated tool. So a lot of times people want to use it for care coordination, and it doesn't quite fit that. Collaborative care was added to advanced primary care. And so that has been pretty helpful. That is actually new over this past January. It used to be that there was a special code for federally qualified health centers with lots of advocacy. They got rid of that, thank heavens. I am glad to share with all of you the Medicare Learning Network document that is sort of the up-to-date, everything you might want to know about collaborative care. They put one out for 2026, so there is one actually that is incredibly helpful. And so we've been really thinking about collaborative care and suicide risk and how do we actually, care for people at scale. Concert Health has several thousand people on their suicide care pathway. And has a suicide care dashboard that we use pretty routinely to help care for individuals. For this particular brief, we actually put out some data, as did the University of Pennsylvania and Kaiser. We all do collaborative care a little differently. We all have slightly different suicide care pathways. But I think at the end of the day, what we are all seeing is that we have the ability to reduce risk in collaborative care. So that if you're looking particularly at the CSSRS and you're taking people from high risk to moderate risk to low risk, or as we say in primary care, from red to orange to yellow, um, that is actually we do have some pretty good outcomes. And so you can see the volume here of individuals that were actually cared for in collaborative care who were at varying levels of risk for suicide. When we think about suicide care and collaborative care across concert, these are some of the things that we have seen, that we were able to get more than half of them to sort of have a risk improvement, and that those that had 15 or more touch points actually had a much greater improvement, which really, makes sense, right? I mean, kind of looking at that, it's like, well, yeah, that kind of figures and tracks. We wouldn't really expect anything uh differently. So here's what I think around collaborative care and suicide care. One is the universal screening. I think if we really talk to primary care, specialty, women's health, pediatric providers, and we say, hey, we have really good data around suicide care and collaborative care, they are way more likely to screen directly for suicide. I think, history has said we, do the PHQ-9 in primary care and say, oh, that's good. We've screened for suicide, right? But we know more and more now that that actually misses a lot of people. It's not the best we can do. And also that starts from 12 and up. And given that we have suicides in individuals who are under 12, then we're completely missing them often. And so what we found is that the ability to really talk to providers and say we can care for those people in collaborative care, then they are way more likely to do suicide specific screening. The ASQ is an example in some of the pediatric practices, or the Columbia scale sort of directly. And also, I'm not sure why my text disappeared here, the monthly case rate. The monthly case rate to me is the biggest gift. I can teach a DBT skill, follow up, and, the next day. Also, I have the ability to talk to someone by phone, by video, or see them in person, either in a practice, in home, in the emergency room. It doesn't matter. That direct care time gets counted towards the episode. So I don't have to worry about, a follow-up phone call not being enough time to count for a visit, right? I have the flexibility within that monthly case rate, and whatever is going to work for the care of that patient becomes incredibly helpful. Also, the registry gives us the ability to have population health visibility. What does that look like? To be able to isolate in a registry the people at risk for suicide, to track them as a population, and really work with organizations to understand and track that population, their population of people at risk for suicide, and really look at that. Also, it really allows for some very significant safety planning and follow-up infrastructure, because all of that time can be included in the collaborative care episode. And so I can talk to someone, do a safety plan, follow up, and I can do that multiple times a month. I can talk to someone and really practice a DBT skill and then follow up the next day. Oh, it worked great at home. It didn't work in school. Let's try something else. So I don't have to worry about meeting the time for a psychotherapy visit or having unreimbursed care. Also, the psychiatric consultation. if someone is at risk for suicide and I see them in collaborative care, I can get a psychiatric consult oftentimes pretty immediately, with my psychiatric consultant, but definitely within the week because I'm sitting down with them. And so at the very sort of outset, a psychiatric consultant is going to review that patient's chart, review that patient with the care manager, and weigh in on care, weigh in on diagnosis, weigh in on next steps, weigh in on treatment. And that is actually really good access. And when we think about collaborative care, one of the things that we teach primary care providers is to say, hey, I work with Kate and she's part of my team. And she helps me care for my patients who talk to me about their thoughts of suicide. I'm going to have her give you a call later today. You're really going to like her. And sort of having that warm handoff. And most collaborative care is same day, next day follow up. So somebody's getting into care right away. They're getting evidence-based treatment right away. They're getting access to that psychiatric consultation. And additionally, because of that monthly case rate and because collaborative care is considered primary care codes, if I have a commercial or Medicare, if I go and see my primary care provider and I pay $20 copay, it is going to be $20 for the month of collaborative care. And so if I'm going to see specialty mental health, I'm going to pay a copay every time I see a therapist, every time I see a psychiatrist, every time I have an interaction, whereas collaborative care is that one copay for the month. Sometimes you will see for the 99494s, but what it does is it makes treatment way more accessible and way more affordable, particularly for the commercial and Medicare populations. So I want to stop there just for a moment, and I want to answer any questions that people might have around like just collaborative care, the model, itself and sort of what that looks like. And it may be different than what you thought and what you've been hearing.
Verna, this is John Fortney. I have a question about monitoring suicide risk with the CSSRS.
Okay.
Um, the time frame for that is kind of vague. Have you thought about which could be like today or it could be last year? How does that work? Kind of trying monitoring that over time with that instrument, or do you use a different instrument?
No, we use the Columbia scale, but it's actually done pretty frequently. So, like, if it happens in the primary care office, then it gets followed up in collaborative care. And, similar to like your other tools, that it actually gets asked, at contact. So, in other words, I'm doing that tool fairly frequently over
But
time.
but but I guess my question is it sensitive to change? If people are feeling better, do they answer differently?
Oh,
Because it's almost like have you ever's. You could interpret
yeah.
one of the questions like
Well,
that.
yeah, the way that we do it actually is have you ever, right, in your
Yeah.
lifetime? And then if the answer to that is yes, has that been in the last 3 months?
Okay.
And then after that, using the since last contact. So
Okay.
if I have not in, since the last contact, so the way that I sort of talk to organizations about doing it is that if somebody is high risk, they've answered, positive to questions 4, 5, and 6, they have intent, they had a recent suicide event that was in the last 3 months, let's just say they're high risk, then they're going to remain at sort of that high risk point for 2 months, a minimum, even if they say no, right? I haven't had an event since last time, since last contact. And we don't move them down. If there's any psychosis, there's a transition or a med change. And so if you've had those things, you are not getting, if those things have happened in the last 30 days, you are not getting moved down. And so the suicide care pathways that we've created for organizations that sort of used nationally has that criteria. And then based on risk, we actually will, talk about how often someone gets psychiatric consultation and some of those things. Did that sort of answer your question?
Yeah. And so when you graph the Columbia scores, they do go down over time. Yeah.
the
Okay.
risk goes down, right? And I think we could talk about risk versus recovery, right?
Uh-huh.
And so essentially, somebody going from high risk to moderate to low to historical is sort of what we track.
Great. Thank you.
See a couple. For us, why don't you go ahead and then there's a couple questions in the chat.
Oh, thanks, Kate. Hi, Verna. I'm Faraz. I'm a family med doctor and researcher at Oxford University, England. Thank you for your talk. Really enjoyed it. One very quick question. In the universal screening, just to clarify, was PHQ-9 used at all? I think you did say you mentioned it earlier. I wondered if it was just the Columbia scale. And the second question is really how are the primary care doctors, how do they find the collaborative care model? I can think of some UK really big collaborative care trials, and it
Mhm.
kind of generated mixed views, and it's not really implemented in the NHS. But I'm just quite keen to hear how do the primary care docs, how do they find um
Um,
how do they
yeah.
find it? Thank you.
They actually love it. And there's some recent articles, like pretty recent, around provider satisfaction. I was actually aware of some of those implementations when they were happening. And I think we've learned a lot about implementing collaborative care. Like, I do not implement collaborative care how I did even a couple of years ago, right? Like, it really has changed. And so what we find is that the providers really have to understand it's their population of patients. It's not just the folks that they think they need counseling, right? And that you have to put some population health measures in, like this is probably going to be strong, but like this crap about the warm handoff and everybody gets, enough patients sort of based on that warm handoff. I have never seen that be true. Very, very rarely. Like, you really have to put some system things in place, and providers have to have enough people in collaborative care to really understand it, because they've only had one choice. Like, I send someone to counseling or they get nothing, right? In behavioral health. And so now, kind of like my diabetics, the broad spectrum, like, we don't send everybody to the diabetes educator for 45 minutes every week, right? Like, there's a broad spectrum of support we provide to that population. And so collaborative care is very much the same for the behavioral health diagnoses. And I think we've learned a lot more about educating primary care providers so that they understand really, and then supporting them. So hopefully that sort of answered your question. But I am definitely willing to talk to you and give you guys some information so you could get it running there for sure. There was a question in the chat. So the psychiatric consultant does not always have to be an MD. They can be an NP. Many of them are. Where you run into some difficulty is that the language in the CPT code says that you have to have full prescribing privileges in the state. And so that sometimes puts a little wrinkle in things. And some states have some weird, like Missouri, you have to live within 50 miles of your psychiatric oversight person kinds of things. And the psychiatric or the collaborative care manager can be someone with a bachelor's. Remember, collaborative care is the identification and treatment of individuals with behavioral health conditions. And so they have to be trained up to be able to care for people within the model. But the answer is yes, they could be. And in fact, Washington has done some great work on the others around training for bachelor's level and certifications, and that she's been a leader in that for sure. Any other questions about the model? Okay, I'm gonna kind of forward here a little bit. So I think we have actually learned a lot about the collaborative care codes, and I think we are starting to do more and more around trying to get some better research around suicide and collaborative care. So if something folks are interested in, let me know. There is a need for additional research, I think, particularly for adolescent and some of the pediatric. One thing that we often hear, people sort of get it in their head. I wish could take the words out, but like brief intervention or brief care, because people sort of get stuck on what that is. But the reality is most behavioral health interventions take 6 to 8 minutes. And then the ability to teach it and follow up the next day, DBT skills. I mean, you can do CBT, SI. I'm actually working with the folks at CAMS, Dave Jobs and his team, to be able, and we're going to modify CAMS for collaborative care. And we've sort of fit CAMS into sort of what would work over a monthly case rate and fit into collaborative care. And we're hoping to try to put that in and roll that out. So the opportunity, when I think about what we want to do for people who are at risk for suicide, we want to identify them. We want to give them good safety planning. We want to treat them. We want to make sure they have good follow-up. All of those things are so readily available and possible in collaborative care. And so really just sort of putting some of those things out. This is a little bit of the journey sort of collaborative care and some of the history. I know that for many years when I started doing collaborative care, back in the early 2000s, we actually used to carve out people at risk for suicide. And it really sort of came to me, I want to say the mid 2000s, where I was like, wait a minute, actually, we have a way better opportunity to care for people, and really started to think about suicide care and actually carve them in way back when I worked for a federally qualified health center. And we saw then that people were way more engaged because we had the ability to really do the follow-up and the outreach. So that was actually pretty helpful. We also really are now trying, I'm sitting today at Pew Charitable Trust, and we're talking, there's a lot of folks from states around here and from some of the hospital associations, and really trying to think about what we need to do going forward to sort of make this work. I've been a huge advocate for using the ICD-10 codes for suicide and adding them to the active problem list, particularly in collaborative care and primary care, and that it is the primary diagnosis for folks that are high risk. And then we say if you're moderate risk, it can be primary or secondary, with a clinical discussion. But if you're high risk, it absolutely must be the primary diagnosis, must be on the clinical, problem list, and sort of doing some of that work and thinking about, I think, has been really helpful. So when we think about some of the missed opportunities, what I probably would have done is really included more of the suicide work sort of back a little bit. There's also a really big misunderstanding that individuals at risk for suicide are going to take a lot more time, and that you're going to exceed the amount of time that's reimbursed in collaborative care. We actually just put a document out the other day. It's on the concert website. Probably should have included it here, but it's there. And it looked at the 99494 codes and the amount of time that people at risk for suicide spent in care. And actually, what we saw is that there was sort of this sort of this rumor that people who were at risk for suicide would just go way above the amount of time in collaborative care, and it wasn't going to be feasible. Again, what we saw is a lot of those follow-ups, those frequent touches, which are not long in length, made it really possible. And that actually, I think, has contributed to a lot of the success. Also, when we think about collaborative care and we think about our Medicare population, the collaborative care codes were added to advanced primary care. It turns out you don't have to use those special dedicated codes now. You can use either those or the CPT codes. The AHEAD model for CMS, where it's in Maryland, Rhode Island, and some counties in New York right now, but is going to continue to grow. Those states are actually using that money to be able to expand collaborative care. And one of the things they're looking to do is waiving some of the copays. So when I think about our people who are most at risk, what would be really helpful to them is waiving those copays, creating access, helping to spread adoption. The access model actually follows people for over a period of 2 years. You're not able to be in access and collaborative care, but it does sort of allow that follow-up and that contact. And then the IBH model, which is in a couple of states. I've actually been a little disappointed about how collaborative care is being rolled into this, but certainly there are some opportunities on the Medicare front. And on the federal front, the Complete Care Act was cooking right along with bipartisan support. And like many things these days, completely blew up last week, and now we're not really sure what to do about it. So trying to figure some of those pieces out. And really thinking about collaborative care across some different populations and doing some different pieces. Also, one of the things that caused some confusion was that the new codes for suicide care were actually added on to the collaborative care or the behavioral health integration Medicare Learning Network. And that created a lot of confusion. You can't actually use them in addition to collaborative care. You can't add them onto the claim. A lot of people who are doing collaborative care, like licensed master social workers, can't use them because in order to use them, you have to be able to bill Medicare directly. So I'm actually working on a project now. We've identified 21 individuals on healthcare teams that potentially do safety planning that are actually not able to build the safety plan code because of those requirements. So that's actually gotten a lot of attention. And so when we think about what we're really doing around collaborative care, you definitely want to think about suicide care right from the beginning. Like I bring it up day one in the implementations. And, when I first started doing some of this, we would always tell practices like, oh, maybe 1 or 2% of your people are going to score positive, suicide. And now I was actually working with a practice the other day, and we're seeing practices like 7%, 8%, so they're definitely going to have people who are at risk for suicide in collaborative care. We've been trying to work with some of the payers to make sure that they're paying the R code on collaborative care if suicide is the primary diagnosis. We had it added in New York State. So really thinking about, what some of those things are and trying to advocate and be supportive. So I want to just sort of stop there and, answer some questions, talk a little bit about, what collaborative care might look like. I'm actually looking in the chat and I'll take those first. The National Network of Child Psychiatry Access. Yes, there is. There's been conversations around using them as the psychiatric consultation. I think what people are finding is that's very hard to operationalize because you're pulling someone offline to do the psychiatric consultation for, 1 to 2 hours every week. And then how do they, how does that get included? The care manager counts that time in their billing episode, but it's really hard to do that if they don't have access to the electronic health record to be able to do that consultation. And so I think it's a good idea in theory, but quite frankly, I'm not sure that it's something that's gonna, be operationalized. Yeah, so John, thank you for answering that question. It's not like you don't spend enough time with Concert Health these days. To be, it's almost like you are part of the family. But I'm glad to answer any comments. I mean, I've written about it some, but I actually feel really strongly. I don't love language for collaborative care, like higher or lower level of care. I actually greatly oppose that language. It's alternate levels of care that we have. But I actually strongly believe that collaborative care, because of the way it's designed and the flexibility, is actually really comprehensive care for people at risk for suicide. And I think the ability to train care managers and to build it in collaborative care will also increase the identification in primary care practices and the ability for primary care providers to have some of the discussions and also be willing to do some direct screening. So there's my soapbox.
I was just going to ask you, Verna, has there been any use of just like portal connections, or are all the outreaches either, by telephone or face to face?
Yeah, so I actually wrote something one time about patients that were including the patient portal in their safety plans, which just sort of happened organically. The problem with the portal communications is that collaborative care is time-based and you're counting the minutes. And so it's certainly a useful method, but it's awful hard for people to know how many minutes to count towards the episode for some of that activity.
Yeah, that seems like something that could be built into Epic. I mean,
Oh, it is.
you know,
Yeah, I think certainly working on it, and particularly the care manager communicating, through the portal, that can actually be tracked. Sure. Yeah.
I was just thinking about, I'm on the national network of the Child Psychiatry Access Programs, and just wondering, is there any, like this kind of presentation? It would be really helpful to hear at one of our we meet monthly with all the Child Psychiatry Access Programs.
Mhm.
But just the idea of the billing. But I'm wondering if, at least on the state level, there would be some way to have like instruction, or, would those child psychiatry access programs be a venue to help implement programs?
I think it could be. And again, I think it's definitely an opportunity. I think you need to train them, and also you have to have EHR access. So what
Mm,
you need to do is, I almost think you'd have to operationalize it. Like that would be the pool of people that might be available for organizations to do psychiatric consultation, right?
mm,
Like, because otherwise I just don't know how you'd operationalize it, because it has to be dedicated time. I'm going through my caseload. You have to have the EHR. You're going to be pulled off of your ability to answer a phone or a call. Like, so, again, I'm
mm.
not opposed to it, and I'd be glad to hash out, different ideas, but that's been some of the barriers and some of the conversations. And I'd be more than happy to come and talk to the group, even so that they understand what collaborative care is.
Yeah. Could you
Ver-
share your email? Would you mind?
Yeah, I can throw it in the chat, sure.
Thank you.
Verna, we just submitted a PCORI grant to compare the PAL line consultation to PAL line consultation plus remote collaborative care without EHR access,
Ooh,
which gives it the equipoise that it might not be effective without the EHR access, because they serve the modal number of primary care providers they serve is basically one. There's like one consultation from that primary care provider, one from another one from another. So there's no way to
yeah.
have access to the electronic health
Yeah,
record.
they're very underutilized. Yeah.
They are.
Yeah. Yeah, I mean, interesting. I think it's actually really hard to do. I mean, I guess they share their screen, but you still have to sign something then, like without having access. And then you also run the risk of that consultation needs to go directly in the chart to the provider, like to have the care manager transcribe that or cut and paste it has like such liability there. Like I can't tell you how many times I've seen that go south.
Yeah.
Yeah. I did throw my email in the chat for anyone who is interested or wants it.
I was going to ask a question, but I think Kate's currently talking and is on mute.
You go first, Sarah, then I'll
Okay.
try to ask it again without
Okay.
being on mute.
Okay, sounds good. Hi, I'm Sarah. I do a lot of work trying to partner with IBH in pediatric primary care specifically and building out suicide prevention pathways in those settings. And I think you mentioned this and highlighted it, but like the biggest thing we're hearing over and over again from PCPs is this lack of time and difficulty getting kids enrolled in collaborative care. And in part because kids especially are mostly reporting passive SI with them.
Mhm.
Collaborative care, IBH, a lot of their clinicians are asking PCPs to manage those kids because they're full or they don't have capacity to see kids for a while. And then at the same time, kids don't want their parents to know, which is kind of required for them to enroll in collaborative care. So I was just wondering if you had any thoughts around this, and this is particularly relevant because we're like right in the midst of partnering and trying to kind of get this.
Yeah, I think for the pediatric practices, having them really understand and identify populations of people right from the start, that they're gonna like all of their kids with ADHD or all of those, so that they really understand what collaborative care is. And then I also really insist, and I was gonna share, we did a pediatric pathway that I can share with folks if you email me. And then there is, I'm just going to pull it up real quick because I think it's going to be helpful to show it. I don't know why I didn't put it in my slide. Uh, but I can share the that pediatric pathway with you, and also some other pediatric resources and things that we've done to really engage the primary care provider, the pediatric providers.
Yeah, that'd be great. I can email you. Are you seeing that in pediatrics, this pathway seems to be working, that people actually are moving
Yes.
into collaborative care from it? Okay.
Yeah. Yeah, without a doubt. And we have really good numbers in the primary care practices and the pediatric practices. And again, it's all around the populations and just saying this is what we do, for people who are at risk. This is what it looks like, right? And like that's just how we care for people. Like, I run the New York State SAMHSA Pediatric Collaborative Care Technical Assistants, and we train the primary care providers. And it's like, okay, if you have a new kid with ADHD into collaborative care. Somebody scores positive into collaborative care. Like it's like, you know, it's not a, it's a requirement of care.
I think what we're running into is the clinics that I'm currently partnering with, they just don't have capacity that the collaborative care within it, the IBH frameworks, there's not someone immediately available necessarily for those kids. And there's a
Which
lot of
is
kids
okay.
increasing suicide risk.
Which actually is fine because a lot of the places around the country, like when we teach that, 15-minute visit, I make the assumption that they don't have a behavioral health provider on site and that the ability then to stratify, right? Because that's really the key is stratifying the risk. So that's why the red patients, I do this, the orange patients, I do this, the yellow patients, I do this. And I actually know what to do, with them. And I'm going to share something just really quickly here.
That's
So
helpful though. That sounds actually really similar to what we're doing. But a lot of it,
yeah,
what we're doing is like a lot more PCP focused things because of
yeah.
access issue.
So this is actually a pathway that we've done that we give providers for suicide care sort of in collaborative care. And this is sort of based off of risk. So, high risk historical is I have a history, but it's not been for some time, but I'm, obviously more at risk. And then on the left are our variables. So, how often and what safety plan are we going to use? How often are we going to do this? The Columbia scale, what does psychiatric consultation look like? How often are we going to have contact with this person? And we have actually modified it to, show prescribing and some other things. So, but this is actually how we work with practices to say, okay, here's how you stratify. And then on the left, here's all the variables that we sort of change in collaborative care based on that risk. And this is actually often really helpful for them, to be able to see it out. And then we train them. This is what I say, and this is what I do. So I know exactly what to do with yellow patients. And it's okay if my behavioral health provider is not there or available, because I know exactly what to do. And I have a much better understanding of risk. And providers, what they will say is it's like the first time that I've actually like known what to say and do. Like a lot of the suicide trainings, they just give me data. I like data's nice, but like I now know, what do I say? What do I do? What do I say? What do I do? And I take them through the 15-minute visit. And then they're like, oh, okay, I get this. Like, this is what I do for asthma. This is what I do for suicide. This is what I do. And I find that it kind of swims by itself after that.
Thank you.
Hey, Virna, I just had a quick question to follow up on Sarah's around how you navigate parental consent for engagement with collaborative care. So I think definitely expect some of the same challenges that Sarah's speaking to around primary care or subspecialty care. In my context, I think feeling hesitant about how do I get a kid that's perhaps in need of collaborative care support, that support without if they're not open to having a dialogue with their parent about the need for that support. So I guess just wondering if in your current model, is parental consent a requirement for engaging with collaborative care, or are there ways to do that confidentially for an adolescent?
So a lot of times you have to sort of go with some of the organizational guidance is. What I do like to remind people is that these are primary care codes and that this is really an extension of primary care. This is not a behavioral health code. We're not billing for behavioral health services. This is part of primary care. So generally, and I'm going to say, unfortunately, a lot of times you have to follow sort of what the organization, wants to do. But I'm a really strong advocate for say, this is primary care.
I guess there's some complexity too around like legal, from state to state, there's going to be some variability
Very
in terms of
much,
what an
yeah.
adolescent can
Like,
consent
yeah,
for with respect to
what
mental
they
health
can
support.
consent for. And also, if I'm in California and I'm doing this, it doesn't matter whether I'm doing it under a primary care code because of who I am and license, it's going to be mental health services. So you run into some of that complexity. And I just learned the other day that if I'm in Utah, I can't actually do anything with the adolescent individually, which is just a tragedy that, I had a glass of wine over last night, but
Totally. No, and we are seeing the same, I think, in our neighboring Idaho with a lot of this kind of really strict limitation
we're
around
going
what can be.
backwards. Yeah,
Yeah,
we're
no
going
doubt.
backwards. And so that's why I've been so vocal, because a lot of these folks really like primary care. And I go, oh, but this is primary care. The primary care providers are doing this. The primary care providers are billing it. So I've kind of been a little bit trying to push it that direction, but
Yeah, I think it's especially interesting just to think about like, if a young person was accessing care confidentially, the billing aspect, if it is billed under primary care, is that actually protective perhaps for like, an explanation of benefits to go home and for that to look like this is a primary care code, this is not specific to mental health. And I think trying to think through, are there ways that if you did engage confidentially with an adolescent, within the scope of the state law, are there kind of ways that may be visible to a parent that hadn't
yeah.
been involved in the consent
The other
conversation?
problem is that a lot of the payers will list for the code psychiatric collaborative care management. And so because they put that psychiatric collaborative care and an EOB goes home to the family, that's also another problem. Yeah. Yeah.
So I have a slightly different question. So I've been trying to think through the relative role of like evidence-based sort of psychotherapy-based care and collaborative care in the context of those folks with, experiencing suicidality, and the research literature has really emphasized that the programs that have a psychosocial component are more successful in moving the suicide needle ideation, not attempts, but at least ideation than the collaborative care programs that don't. And kind of thinking about like you're doing a very facile, classic sort of collaborative care model of being in regular touch with people and providing like small doses
Hmm.
of care, but you were also talking about working with Dave and makes me think of sort of more like full session related. How do you all normally negotiate that? Is that like a billed as a
Yeah,
mental health code
no,
and would happen at this
no,
like by the provider, or do you refer
it is.
out?
No, it's all done under collaborative care. So, at Concert, we only employ licensed clinicians. That's just me, quite frankly. But so what we're thinking about with CAMS is that it'll be like a 30-minute, 15, 30-minute, 15, and that'll just be every week. And we'll rotate that. And then we'll do the 8 sessions of CAMS that way. So, starting to think about some of those models and how they fit in, I think is going to be, really important. But yeah, and we have people that do, CBTSI.
Hmm.
So, collaborative care doesn't exclude that. It's just then what's the amount of time that I'm spending with someone? Like talk treatment or weekly treatment could be done under collaborative care, you
So
know?
particularly under the if in the states where you said that like 4 hours a month was allowed, because what I was thinking is, oftentimes with these evidence-based suicide care treatments, you kind of need a lot of treatment in a small window of time and then it drops away.
Yeah.
And the systems with who provide like monthly services often aren't really set up on the assumption that there's going to be a lot at once and then it's going to drop away.
Yeah, there are like Medicare says that you can bill 4494, so you would get that amount of time. But some of the payers and states haven't followed suit.
Hmm.
So I think those are some things that, to be figured out. But
If
or
you,
how is it broken up? So in other words, how are we maybe having someone do something offline, right? And then it's a shorter time and an activity, it's a shorter time and an activity, or it's broken up, into, doses.
Mhm.
So, maybe it's two shorter thing touches a week. Like, and we spent some time thinking about that with CAMS, right? Like, how could we still, have the effectiveness of CAMS and still, fit it into collaborative care in a way that was going to, be self-sustaining and viable.
Is there, because collaborative care is a primary care code, if somebody was simultaneously in uh bi being billed for mental health services through a psychiatry mental health code, are those allowed to occur simultaneously?
They're not, it is a duplication of services in many ways. Some payers will not pay it.
Hmm.
So, you really want to think
Want
about
to
it. Could
pick
I
one or
be
the other?
Yeah, could I be getting like my medication, if I'm a kid from a psychiatric provider and be in collaborative care? Yes, that does happen, but really, you know,
But you wouldn't do a psychotherapy
no, no. Some
simultaneously.
people in states where the codes haven't passed, some people will do like collaborative care, but bill the psychotherapy codes. Some people will want to do a split model where they'll have like a therapist billing therapy and then someone else doing collaborative care. I actually don't think that model is particularly successful. You have someone
Hmm.
doing what they're always doing and someone doing this, and they're not really coming together in what is really the
Hmm.
spirit of collaborative care. And so I don't love that, but
Yeah.
I
Yep.
think it also depends on what you're trying to do. There may be some models where it might work.
Yeah. No, that's very helpful. Thank you. Other questions, comments?
Well, thank you, everyone. It's always a pleasure to get to talk to folks and always glad to talk about collaborative care. So
I so appreciate having such a suicide care focus to talking about collaborative care, because I think this is a really unique population that you have, jumped into with both feet for a long time now. And I think that's really critical for the folks who are developing things within our center. And I really appreciate you coming and presenting this to us and having enough time for this kind of discussion.
Yeah,
This was
no
really
worries.
helpful.
Yeah, let me know if anybody, wants to have further discussions or has questions, then, please feel free to reach out and let me know. I could certainly talk about collaborative care all day and suicide all day. So, be careful what you wish for there, but, glad to be helpful.
Thank you so much. Take care, everybody.
Thank you. Bye.